Wait until it's not, are you running?
Good evening. I'd like to open the St. Andrews Task Force meeting this evening. First on the agenda, we have reports. And first up, Community Hospital Work Group.
All right. Well, this is going to take a little while, so I'm going to stand up here. I've handed out a few of these copies, but maybe a few more on the table. I'm sure Peggy will make sure they get in the record and we'll put them in the binder. So our group, our working group on Community Hospital has been going around and talking to the executive teams of different critical access hospitals in Maine. And we have now met with the executive teams from Blue Hill Memorial, which we did today, C.A. Dean in Greenville, Down East Community in Machias, Holton Regional, Mayo Regional in Dover-Foxcroft, Penobscot Valley in Lincoln, Reddington Fairview in Skowhegan, and Sebasticook in Pittsfield. And we still have 2 more to do. And in each case, we've met generally, in almost all the cases, we've met with the entire management team for 1 to 3 hours. So these are substantive discussions. And so what I'd like to do is just give you some highlights. And the first thing that we noticed was that all of these communities are economically depressed. They're all they all have high unemployment, they all have high Medicaid, main care populations, a lot of people who are uninsured. There were a couple that seemed to have done, a couple of communities, independent of the hospitals, that had done interesting things that I wanted to mention. When we talked to the people at Mayo Regional and Dover-Foxcroft, they talked about their high school and the fact that their high school was not able to sustain itself. They couldn't, they didn't have enough money, they didn't have enough students to have a decent high school education. So their superintendent of schools went to China and came back with 110 boarding students who pay $10,000 each for the school, not including the boarding part. So they now have 110 new people living in this community, and the school has gotten much, much better. So I thought that was kind of an interesting, innovative thing to do. And apparently the students are very happy, even though I would imagine they'd be cold.
Well, many parts of China are quite cold.
That's true. There are many parts of China that are cold. They did say that one of the public health issues that came as a result of that was that these kids needed a lot of sex education. Because where they came from, they didn't have any, and now all of a sudden they're in this new free country, and they needed to know about safe sex and contraception and all of those things. So that was their biggest health challenge with them. And then the other town that we found, and Dorothy, you had more input than I did, but we noticed that Sebasticook in Pittsfield seemed like a town that is revitalized. And Chianbro is there, and the hospital is adding on, and there's just more kind of economic activity in Pittsfield than we saw in a lot of other places. So that was kind of interesting. So basically, as I mentioned, everybody is reporting very low income, year-round populations. Everybody is also reporting that their populations are aging. And they are all reporting that the emergency room traffic and their inpatient traffic is declining quite rapidly. And in fact, several of the CEOs said, just in the last 3 months, we've noticed a decrease in our emergency room intake of about 17%, and we don't know why. Then later, when we went to C.A. Dean in Greenville, a very with-it woman who runs the emergency room there said, well, what I do is I look at the Medicaid, the main care reports that come every single day, and they tell me for the people who came to my emergency room last month, how many of them are coming back and whether they're turning up at the primary care physician's offices instead of the ER. And she said, I know that what's happening is the case managers for main care are being very aggressive. Every time somebody goes to the emergency room and they shouldn't have, they get a phone call now. And they're told, don't do that again, go to a primary care physician, this is where you should be going. So that, I think, is probably what's going on to cause fewer and fewer people who probably shouldn't be going to the ER to not go to the ER. But as one CEO said, you know, we don't want the wrong people coming here, but the fact of the matter is we look at ER admissions as inpatient admissions. It's kind of the front end of how we get people to come and actually use our inpatient beds. So it's a good news, bad news story. The other thing they all basically reported, and I mentioned this last week, is that the outpatient portion of their revenue keeps increasing as the inpatient goes down. So now, of the 8 hospitals that we visited, the average is about 77% of their revenues come from outpatient. And the 33% that's remaining is from emergency room and inpatient services. So, and then you can see the reimbursement mix. And I did want to mention that the thing that really struck me, whenever you go in to talk to them, to these executives, almost the first or second thing they want to tell you is how many of their people are on Medicare, main care, commercial, self-pay, etc. It's what's in their heads, first and foremost, is reimbursement. How are we going to get reimbursed for the services we're providing? The thing that isn't in their heads, first and foremost, is what conditions do my people have and what healthcare services do I need to provide? Because they can only provide the services they get reimbursed for. So, for example, we asked a lot of people about mental health services, and they all said, well, we would love to provide more mental health services. We can't get reimbursement for it. So it reminded me of a situation I was in probably 10 years ago in the state of Massachusetts when I did some work with the Health and Human Services organization for the entire state, and we had a bunch of stakeholder meetings with all the different people from all the different agencies, and everybody was talking about what their issues were, and we drew a big map on the wall of, you know, all the issues that everybody had around patient care and taking care of people in the state. And the commissioner walked in to the room, looked at the map on the wall, and burst out laughing. And he said, you've just drawn a picture of exactly what our problem is, which is that we spend all our time worrying about whether or not we're going to get the money from Medicare and whether or not we're going to pay it fast enough to the providers. And we don't worry at all about whether the person who's getting the care has actually received care that they're satisfied with. We have no feedback loops. So that was 10 years ago, and I kind of came away thinking, well, I'm not sure anything has really changed a whole lot. We've got all these new metrics, but it's all about reimbursement, which makes it very difficult for us as a community to plan what we want St. Andrews to be. But here are the best practices that we saw. And again, across these 8, and this will probably change slightly. This is kind of my first pass, and some of my colleagues haven't had a chance to weigh in and say, wait a minute, you forgot this, or whatever. So take this as draft. But one of the things that Dorothy and I were very impressed with, probably the hospital we were the most impressed with, was C.A. Dean in Greenville, which is the one that is closest to St. Andrews in size and community. It's different in that it serves a vast geographic area, but a very low number of people. And what we noticed there is that there is no $1 million CEO or even $500,000 CEO. There's a paramedic who is the CEO of this hospital. And when he's not in meetings or planning strategic plans or meeting with his board, he's on his snowmobile rescuing people who need help. And he runs the ambulance service. And the entire executive team were all people who served patients. So kind of what we took away from that is, wait a minute, if you're little, like St. Andrews is, you can't afford an executive staff. You need people who are practical. You need people who are hands-on. You need doctors and nurses and people who are going to be out there, you know, on the front lines. So that was kind of an interesting takeaway. It was at Mayo that having just said you don't want executives, there is one role that seems to be very important to all of these hospitals, which is the person who recruits physicians to come and work in the local region. And of course, if you are in Bolton, or if you're in, where was the one that was, I'm trying to think of, anyway, way up in Machias, right. You know, it's very hard to get physicians to come from New Jersey or New York or Massachusetts or whatever and come and work where you are. And so they're full-time people whose job it is to basically recruit and keep physicians happy. The best ones we saw were kind of a combined hybrid of you know, recruiter, HR. They did HR for the entire organization. They were kind of the PR communications person, because of course they have to tell the story all the time about why we're such a great place to work. So that turns out to be a pretty important job. Then when we got into the actual staffing of the hospitals themselves, in the ER departments, there's a lot of variation depending on how big they are, but one of the things we liked was at Blue Hill, the ER physician isn't an ER certified physician, board certified physician. He is board certified as a physician, but in family practice, family care, and he's a hospitalist. So basically his job is he's at the hospital full time, and when there's an emergency, he's in the emergency room. And when there isn't an emergency, he's tending to everybody else in the hospital. And that seemed like a pretty good model. And then when he or his replacement isn't there, a lot of these smaller places, what they do at night is they have nurses, RNs, or physician's assistants, and they have a doctor on call. And the doctor gets there pretty quickly. So the idea of having to have a board, you know, an ER board certified physician 24 hours a day just isn't the case. It's not what most of these hospitals are doing. We thought it was pretty interesting, again, that in Blue Hill, one of the things they did to recruit hospitalists, and of course Blue Hill is a lovely place, just like Booth Bay is, but they offered people a job where they can come, doctors can come and work 26 weeks a year. So they have 2 of them, and each one works 26 weeks a year, and they just do 1 week on and 1 week off. So they can go have, you know, another private practice, they can go sailing, they can fish, they can do massage, they can do whatever they want the rest of the time, and they apparently like that flexibility. Many of them use telemedicine for trauma. We did pick up from the CEO at Lincoln that there's a gotcha, which is a reimbursement one, which is that if you use telemedicine in your emergency room or in your ICU, and the doctor you're consulting with is in the same county, you don't get reimbursed by Medicare or Medicaid. Somehow they assume that they could have just driven over and helped or something. So you need, if you want to get reimbursed for the use of telemedicine, it has to be like from here to Portland or from here to Boston or something. It can't just be from here to Miles. That wouldn't, we wouldn't get reimbursement for that. At CA Dean, one of the things, I'm going to jump down to inpatient and kind of come back around. One of the things they did that saved their bacon, they were losing $1.6 million about a year, about 3 years ago. And what they did was kind of interesting, and I don't know if it would work for St. Andrews because I don't know how it would relate to St. Andrews Village. But what they did was they had a nursing home, which they downsized and delicensed. So they took it away from being a nursing home, and then they moved 15 of those patients into their hospital. And they have now a wing. They call it the East Wing, is basically a nursing home. But they don't call it a nursing home because they're not supposed to call it a nursing home. They are licensed to have patients who get to stay, you know, are long-term care patients. They can stay there till they die. And they're paid at a rate which is the average for the state of Maine for Medicaid Maine care reimbursement, which is $185 a day. And that's room and board. But it made the difference for them between having a whole bunch of empty beds and having 15 people who are paying $185 a night. And you know, they have nursing staff supporting them, and of course doctors. And the same. And then what they did was they trained the nurses to be very flexible, so the nurses are willing to do both the nursing home kind of care and work with acute care patients. And that was a kind of a big deal for nurses apparently to switch back and forth between these two different types of nursing. But they basically said, if you want to work here, that's what you get to do, and it's worked out really well. And we were very impressed with their head of nursing. And then the other thing that they did, that they were the first ones to tell us about it, but it turns out a lot of these hospitals have done it, is, and in their case at CAD, they just did this recently, like 9 months ago, they hired a full-time patient financial counselor. So when you come in for care, unless it's a real emergency, you'll sit down with somebody and they'll work with you to figure out how you could best pay for this service. So they said, for example, a lot of people are eligible either for main care or for other programs, like their programs for women, women's health, and so on, that most people don't know about. And they do know about them, and they will fill in all the paperwork for people and kind of make sure that it gets in, et cetera. So that has made a big difference in their percentage of getting reimbursed, because they're being very proactive about it. And the patients apparently don't feel that this is like, oh, wait a minute, I've got to go talk to the billing person before I can see a doctor. They're actually, this person's very caring and warm, and they make it very, very clear, we want you to get your health care. We are not going to keep you from getting treated. We just want to make sure that you get, as much support as you can, as you're entitled to. So that's worked for them very well. And the other thing they all said, and this relates to the affiliate relationship, is that what's very important from a reimbursement standpoint is your billing and the coding on your bills has to be extremely accurate in order to get the best reimbursement. And so what they basically all said is there's no way a small hospital can do this. It is very expensive, it's very hard to do it well. There are too many different regulations and too many different insurers. This is why you need an affiliation. You need somebody who will do this billing for you. Now, some of these hospitals were not affiliated, but they had IT systems they used to do billing, and those IT suppliers offer that service. They have people who do the coding and so on. And they do it based on actually looking at the patient's records and trying to figure out what actually happened. So as I mentioned, the other thing that they did from an inpatient standpoint, and this is true with Blue Hill and CAD and probably a couple of the others, to fill their beds, remember as a critical access hospital we have 25 up to 25 beds, acute care and swing beds. What these folks are doing is they basically call main care or email them every day and say, we have 5 beds available, we have 7 beds available, we have X beds available. And then as soon as somebody pings them and says, or calls them and says, we have this patient, can you take them? They promise to look at that patient's record and give an answer within 60 minutes. And that's how they're filling the beds, because they can be very responsive. They're being very proactive and they're being very responsive. So, that's just pretty simple process stuff that I think we could be doing if we're not already doing it. So in terms of making money, what everybody basically says is the same thing. You need to have surgery, and it's probably mostly outpatient surgery, and ideally you need regular internal surgery and you need orthopedic surgeons. And they don't have to be there every day, all day. They need to be there 1 or 2 days a week. So basically, start with 1 day a week surgery, move to 2 days a week. CAD, which as I said is even a smaller community than us, is doing 3 days a week, or both orthopedic and internal surgery. And so they basically have surgeons who will work elsewhere and then come and see patients there, and they have them, they schedule them, and they provide the nurse, and they provide the operating room, and they provide the labs, and they provide the diagnostic imaging and everything else they need. But it's the way you make money these days. So we need to get that back. Right now, that's all over at Miles. The other money makers are your lab, having a lab and being able to do all the lab work yourself 24/7. And I think, I can't remember the numbers, I think they said they had done, at CAD, and I think they said they'd done like 90,000 lab tests last year. And again, what they did was they actually had doctors go out to nursing homes with the phlebotomist and visit with patients and say, would you like us to take, you need to get your blood checked, or you need to get a urine sample or whatever, bring it back, do the lab work, give them the results, etc. So they're doing outreach to collect the lab work. Diagnostic imaging I mentioned, infusion center, and this is something Judy Stone had suggested to us, which is, a place where people can come and get shots and get various kinds of infusions and have things cleaned and so on. And again, they've done that at a couple of places and aggressively recruited patients to come in for those services, including seasonal patients, because a lot of seasonal patients need those services. And chemotherapy, not everybody has it, but some of the ones that have it have been able to do it without having a full-time oncologist on staff. They have an oncologist who visits maybe once a week, and then they have telemedicine, so they can talk with the patient and the oncologist and the physician's assistant locally, and just make sure the chemo is working out okay. And then last week I mentioned that becoming a rural health clinic, everyone we talked to had done this. So, they've applied and become a rural health clinic, which means you get higher level Medicare reimbursement for basically your family care center, where your physician's offices, if you call them a rural health clinic and you do the number of hours of patient visits that you need to do in order to qualify, you will get total cost reimbursement, not just, what do they call it, allowable cost, which is what we get for the critical access hospital. And then both Blue Hill and CAD talked to us about how they work with their seasonal patients. And in Blue Hill, one of the things they've got is they've got some doctors that are so good and so welcoming and so well respected that they have patients from New Jersey, New York, Massachusetts who actually put off their medical stuff and do it when they get there for the summer. So that has actually become their primary physician, and the specialists at home are the ones that they see when they have to. So that's pretty interesting. And at CAD, what they do is they do very proactive outreach, trying to make sure people get referrals before they come. But the other thing they do, which I think is brilliant, is they have open clinics, walk-in clinics at the doctor's offices from 7 to 9 every morning. So anybody in town who needs to go to a doctor, you don't have an appointment, you don't have a primary care physician, you just turn up between 7 and 9 and you will see a physician. And it's kind of like, well, hello, this seems like it might make sense. It's a walk-in clinic, but it's not a separate place. It's just you go to the doctor's office and a nurse practitioner or whatever will see you and then figure out who you need to see. And so that's another way the seasonal people get then funneled into whichever doctors. And my thought for here is we might actually want to think about doing 2 of them, one over at St. Andrews Village and one at our family care center, so that we could make it easier for the people at St. Andrews Village to have a walk-in clinic, and that might be at more convenient hours like 10 to 2 or something like that, as opposed to first thing in the morning. And then all of them, in addition to having kind of a core group of family care practitioners, pediatric, OBGYN, internists, for all their specialists, they basically had organized specialty doctors who would come once a week or once every 2 weeks. So for urology, cardiology, oncology, etc., you basically just pay $2,000 a day or so for a specialist to come and see all the patients and you line them up. And we've done that here in the past. Excuse me. I think on the telemedicine consults, I've already talked about that. I did mention reimbursement problem for telepsych. A lot of people talked about telemedicine in the ER, but excuse me, but they also talked about using telemedicine for mental health. And so Acadia, which has psychiatry, has a facility that you can connect with their psychiatrists using the telemedicine. And that actually works pretty well. People don't seem to mind doing it. So there's the reimbursement problem, but I think it would work. So I think that's basically it as far as what we took away. The strategic ideas I talked last week about the wellness program. We did get one suggestion under mental health where Sandra, I don't know if you want to maybe just say a couple words about putting you on the spot while I'm using my voice on kind of the mental health outreach we've been thinking about doing.
About working with the Y and the school system and integrating all those people in touching base with kids, and because there's a big addiction problem here on the peninsula with the kids, and we were talking about back and forth setting something up, but integrating the Y, for exercising and stuff, and the school for kids that are having problems, and working with that whole population to provide some sort of outpatient or, affiliate with someone who has inpatient too. But it's a whole big integrated thing that we talked about.
Yeah.
And then getting probably a couple of psychiatrists to perhaps not be on board, but be available to people we get problems with. Yeah. And then work with the police too in reference to kids who are out of control, and work some sort of a system with them too, and incorporate all that.
And it was the CEO of Mayo who's actually
doing some of that.
Who said, if he were in our shoes, what he would do is he would pick a niche that is underserved in the state of Maine and focus on that. And he said, if I were you, I would pick mental health. Because there are just way too few mental health beds in the state of Maine. And he said, if you could do it, he said, I would build a 10-bed mental health facility on your campus and hire a psychiatrist, and he said you would be full all the time.
There's not even a question. Again, I work in corrections, and believe me.
But you could also be a resource for outside
Not
of this
even a
area.
question,
Right.
for the whole
Yeah, I mean,
state. They'd be
the whole
bringing,
state of Maine, because there
you'd
isn't
be
any.
bringing them from all over the
Right.
state. Every county in the state would be sending kids, or people, or whoever.
Right.
So you would fill those beds up. You would have them filled.
So that's basically what
Thank
we've
you very
got
much,
so
Paul.
far.
That's awesome.
I've not made trips out, but I've been on several of the telephone conferences that we've had, and I was really struck with the CEO of Machias and his complete. He was very candid with us, but one of the things that he said was that for quite a while, nationally, the people that are making the decisions about health care are only worried about reimbursement and the bottom line. Right. They're not worried about the patients. Right. And he said that's what's wrong with everything. He said it's crazy. It's turned upside down. And so it was heartening to hear that some of the people involved with these small hospitals are the ones who really care about people. And it's been very enlightening. And Patty needs to be, she's a saint.
Yeah, right.
Yeah.
She's been really on that.
I'm learning a lot.
Mike? Hey, my apologies for a real boring question. Regarding the rural health clinics being reimbursed on a cost basis, does that include a fringe load
I can't figure that out, because one CEO said to me, if you're paying $3 million for your physicians a year, you will get reimbursed $3 million. Then another CEO gave me some salary ranges for physicians, and then he said, so you can get, a good physician for $150,000 a year, but remember that they're going to cost you $150,000 a year of overhead. Which I was assuming, and I didn't get a chance to follow up with him, I will, but I was assuming what he meant by that was benefits and liability insurance. So,
Well, there's a whole array. I'm thinking of.
exactly. So I
College
don't,
university gets a grant,
right,
20 to 70%, depending on where you go.
yeah,
It's taken off the top for the roof over their head.
right. Right.
The parking, the cost of maintaining the facility.
Yeah, well, that is part of the total cost.
It is.
And if you, one of the things they said was, let's take our family care center that's over there now at St. Andrews. They said, be very careful when you bring in specialists who aren't part of the rural clinic. They have to have a separate area that they work in, because you can't bill that out. So, and Peggy Pinkett warned us about this a long time ago. She said, you have to measure the corridor space, you have to make sure the break room is used only by these doctors and not by other doctors, et cetera, because they're very precise.
So there's accounting involved.
Yeah, exactly. Yeah. But I don't know that,
But it isn't just direct
no.
cost of the person
Right.
giving the care per day.
Yeah.
Tom?
I'd like to say something about the subject that's currently being discussed, which is that healthcare nowadays consists of a tremendous amount of effort that's spent to make sure that any care that gets delivered, you've got some source of money to pay for it. And we mentioned in the past, it has been mentioned here, starting with something that Smith said, that the healthcare is in a state of tremendous flux at present, with Obamacare, for example. The fact is that flux is not going to stop. It's going to continue. The reason being that at least some of us are convinced that the present system is crazy. It's just wrong. And it was very interesting to hear the report of the person from the CEO of Machias, who is one of the few people that has been talked to who has been able to rise up above the present system that prevails in order to see that. The interesting thing is that one of the questions that Patty's group asked, I participated in one of these telephone visits, and the question that I asked at the time was, everybody knows that healthcare is going through a big transition. What about the possibility of Maine becoming a single-payer state? And the answer I got was interesting. The answer was, look, the chances of that happening are so small, the cloud on the horizon is so small, that it's not what we're worried about. We're worried about, can this bed be paid by that source of federal money, or this source, or some other source of state money, etc. These guys are so busy trying to keep the plate spinning on the sticks that they're, with rare exception, and Machias CEO I think is such an exception, are so busy doing that they can't even think about the possibility of another system. But I want to offer my own opinion. This is my own opinion. In 5 or 6 or 10 years, we will have a different system. This business of everybody being preoccupied with who pays for what will go away.
Potentially it will, yeah.
Potentially. Which means that whatever we're doing now has to, in the first place, whatever we're doing now has to accommodate the current reality, which is that that's how you do it. And there's just no question about that. But we also have to be prepared for the possibility, as we've said in the past, that healthcare in this country is undergoing rapid change. And among the things that will change, in my opinion, is that whole focus on where do you get the money to pay for it.
Thank you.
Any other questions for Patty?
Our doctors down here, and I assume at Miles, are all paid by Lincoln Health. They get a salary every week or every other week. Are these rural hospitals doing the same with their?
Yeah, what they said is that you want employer-owned physicians' practices for all of the full-time physicians. But they recommended that they be not totally salary, but salary plus incentive for making sure they're being productive. And the specialists that come in for 1 or 2 days, that's different, and usually you're paying them by the day or by the, whatever amount of time they're spending.
And also on these lists of things that you had said, like oncology. You know, we used to have a nurse that came down here who did oncology.
Right.
We used to do day surgery
We
down
used to do
here.
all this stuff.
We used to do all this
Yeah,
stuff,
that's right.
except it's all been taken away by Lincoln Health.
We used to have a respite program
Yeah.
wherein if you were going away, you could bring your elderly grandmother who couldn't be left alone, pay by the day. She could stay at St. Andrews while you were elsewhere.
Yeah,
And that, I don't know why it went away, but it went away when St. Andrews stopped, well, basically at some point when St. Andrews and Miles,
It probably went away when they couldn't figure out how to pay for it.
well, no, this was not paid for by
Private
insurance, it
pay.
was all private pay.
private pay, yeah,
Yeah,
right, that's a really good point.
Yeah.
Dan, so thanks.
and it was actually it was a well-used program, and it was a great relief, because people knew where the people were not regarded as patients.
Yeah.
If they became ill during their respite stay, they were taken to the emergency room as outpatients, as though they had come from, say, Fisherman's Wharf.
Right.
Anyone else? Thank you, Patty.
Big thing.
Next under reports, data analysis report. Anything new to report, Mike?
No.
Volunteer coordinator.
Can you put me back with fundraising at the end since Valerie's not here? I'll just do it all at once.
I can.
We just did.
BRAS work group. Anything new to report, Robbie?
No, we're still working on the budget issues with Lincoln County Healthcare. And with the new change in the dates, that makes our budget issues a lot better. So we should be having final budgets for next year that will be out within a few weeks. Now that we have some information and can plan, we'll get that information all finalized and out to everybody. It's time to start our budget process anyways for next year with the town, so that'll be out and be approved and ready to go to the towns for their approvals. And last I heard, I didn't go to the meeting today at St. Andrews, but I believe it's sounding more and more like Lincoln County Healthcare is going to have to negotiate directly with the towns for reimbursement.
And I'm looking forward to it.
They're not going to be able to negotiate with us. We're going to have to put together the budget as we would any other year. And if there's a subsidy from the hospital, we'll have to go to the towns to offset what they've paid for ambulance. It won't be able to come directly to us, which is where we thought it was going, but it's getting more and more clear that that's where it's going. So you groups of selectmen will have the opportunity to review and work with them on that.
Patty?
So one comment I have about that, and you guys might think about, and certainly the selectmen should think about, which is, it's one thing to say, okay, this subsidy will work for this year, but can we get some kind of an agreement that will say how many years they're going to be willing to do this? Because there was some discussion early on in this cycle about, well, 4 years or something like that. And then what happens? Then we're back to square one. We have to come up with another $500,000 somewhere.
Yeah, you're back with the town's foot in the bill, is what you're back with.
Yeah.
Tom?
There's another kind of bit of craziness in all of this, which is that the budget that the BRAS will put together of needs has to assume that the St. Andrews will close on October 1st. Which normally you would think that that means that, well, we've got to be ready by October 1st. But the budget that they're putting together assumes the fiscal year starting July 1st, which entails tax monies that have to be contributed by the various towns. Therefore, the town budgets need to be ready for vote at the town meetings, which are going to occur in March and April, as I understand it.
March and
May.
Or whenever.
Yeah.
Anyway, long before. So the question is, do the towns have to assume that the hospital will close? Well, yes, of course.
Without question.
That's what they have to assume. And therefore, the question is, what happens? This is just something that I thought of in the course of the past couple of days. What happens if the budget for the increased ambulance service that's needed in the event that St. Andrews closes on October 1st, which is what everybody has to plan for, suppose those increased taxes for the ambulance service that will come out of its budget exercise are not approved by the voters. What happens then is the question. It's
You will be putting Boothby Region Ambulance Service in a very difficult position.
Right.
exactly,
Pure and simple.
yes.
You'll put them in a completely untenable position.
Right, and the question is, it seems to me that this again is one of these bits of craziness that results from closing St. Andrews even on October 1st, which is that there isn't any way to plan for it in one sense. Assuming that people are as opposed to tax increases as so far all the evidence seems to indicate that they are.
It's an issue, no question.
And I would assume, Robbie, on the opposite side of that, if the ambulance service is to put together their budget anticipating the closure on October 1st, and that doesn't happen, you'd only bill the town's actual cost versus anticipated cost.
What we've talked about, and we haven't finalized it internally, we are gonna have to budget for the hospital closing October 1st. We know that. The towns are gonna have to go to the town meetings and get money approved, like the hospital is going to close October 1st. But I think that what we're gonna try to work out with our budget committee is a different payment schedule. At this point, when the first allocation of taxes comes into the towns, we get our subsidy up front. And I think what we're going to propose is some sort of a stepped, so we can see, like you said, if October 1st comes along and this gets delayed again until January, another 6 months gets bumped onto it, then we'll have to look at the budget and come back to the towns, and what will end up happening is, if there's money that we don't collect from the towns will have that to offset the tax burden in the following year or however they. But no, we don't expect the towns to give us all the money and then wait and see what happens. We're gonna work through that as best we can, because we know the towns aren't in any better position than we are with the whole thing.
I have every confidence in the ability of the four towns to work with the ambulance service. It's always has, and we will continue to.
Great. I don't see Mary Ellen Barnes here this evening, so we don't have anything from Lincoln County Regional Planning. I have no new update on the legal workshop. So, Peggy, you're it.
All right, Chuck. We have been talking so far about the hospital, and we've been talking about where do you go to get the money to pay for it, that we can't have these services unless they're paid for. Now, correct me if I'm wrong. Haven't you said from day one that we have to keep raising money for this effort, or we have to stop it? If we can't pay for it, we have to stop it?
There's not even a question. I mean, we still are in a position, we have had largesse from people that has been a blessing, and it has gotten us to where it has gotten us, but we are without question in a position where we still need to have people making contributions to this process, and if they don't, it comes to a screeching halt. I mean, we cannot go where we don't have the funds to take us. So I would like to speak into that camera if I might, and didn't want to overtax you, but thank you very much. We need to have continued support from people in this region, in all 4 towns. If you believe in this project, if you believe that this is something that's worthwhile, if you believe that what we've done up till now has been exemplary and that we're doing the right thing, we need you to continue to contribute. We need you to dig deep. It's the holiday season. I know we're all, scratching to make things happen for everybody, but this is what we need for this region. So I beg you folks to continue to do the best you can to support us. Thank you.
All right, so now I'll come this way so you don't have to do this. We should tell everybody that John Trees is not here tonight. Channel 7 needed to go to the basketball game, and he didn't realize it was the same night. So I said, oh, well, I'll bring a camera. So there's the camera, and we have a new operator tonight, so bear with us. It's my husband, for all of you. After last week's meeting, when we got the wonderful news about the delay, the response from the community was difficult for me because there were people who had that mother instinct who didn't want our task force members to have their feelings hurt. They worried about them in smaller numbers when they would meet with Lincoln County Health, and they wanted it to be an even match, and well, a lot of worry started to happen. So I thought we needed to turn that energy around. And on this week's update, we have the messages that came through. First of all, we need to let you all know that even if it might sound like we're worried, we're not. We know this is a slow and delicate process. We, as volunteers, disagree with me if you want to. We as volunteers continue to provide positive support for our task force.
Yes.
We back you 100%.
Yes.
And we know that you know what we all want at the end of the day. So, that said, yes, money is important. And I'm going to let the people who are doing things here at the end of the year talk about what they're doing, because we want to fund the strategic plan before the end of the year. And that doesn't mean fundraising is going to stop, because we need to continue to make money in this very begging way. Last week, before the meeting, Jim shared with me that with what was in the money for the strategic plan, what we call the second opinion fund at the first, and with what's left, with what we've raised here with the task force, we have enough to pay our bills. And that's that we pay Julius for his position paper, and we will be able to pay for our strategic plan. We have hardly any wiggle room after that, which means that there's not extra money for contingencies. So we need, right now, before the end of the year, $20,000. And it can go straight to the first people are going to talk to you about that in just a moment. But before I let them talk to you about needing more money, I do want to tell you that office hours are changing for the holidays. It's in your update. I also want to tell you, Libby says I'm losing my mind, and I am. So
It's a small loss.
yeah, it's a. Okay, then what was the other thing? Anybody who would like to write press releases or coordinate a PR plan, a publicity plan about this effort, please let me know. It's very, very hard to get answers for things, but if somebody is diligent about trying to put together the information that the community is asking for, and let me tell you the kinds of things that are coming to me. What's a strategic plan? And we're trying to fund that, so if there's that question, then indeed we need to be able to put out a release about what a strategic plan is. Did the lawyer and the consulting group work together? Are they in the same office? Somebody probably could search that information out and help our community better understand the relationship between our position paper and what we're going to get at the first of the year with a strategic plan. Let's see what anyway, that's the kind of thing. We just need to be informational about what's happening. And with that, I will start out the fundraising things by telling you that all donation boxes that are around town will be going into the Second Opinion Fund, and we're asking anybody, when you see a donation box, stick a big bill in there. To date, as of today, we have 800, the donation boxes have given to our cause $899.18. So do not doubt that little things mount up. And so if you put a big buck in that box, I'm calling it Jack in the Box in the press release this week, by the way. If you put a lot of Jack in the boxes, then there'll be a lot of surprise when we open them up, and we hope for that. Okay, all of you people who are doing fundraising things, stand up and tell everybody about them. Go ahead.
Okay, hopefully, I'd like to get the names and addresses of all the people in the associations, like Capitol Island, like Juniper Point, any of those. We have sent Squirrel Island, so if anybody knows how they can get a hold of a directory, and I'm sure every single association, probably except ours, has a directory. You know, this would be great, because I was under the impression that probably every summer person gets a register. They don't. They don't. I was amazed to find out that some of them had absolutely no idea what's going on. So what we've got to do is get a letter. I'm hoping Margaret said she's making me one, because I don't write well.
I've written the letter.
And I hopefully by the end of the week I should get Capitol Islands Association's directory. And if anybody knows anybody in any of these other associations and can get me a directory, I'll see that the letter gets out to them. Okay? Oh, and I put it out on Facebook too about the first and donating money. And I sent it to both my girls to put on their page, and I'm hoping other people. Do you have a Facebook page, guys?
I don't think you guys have an address.
Why do?
Yeah, but he's not going to tell us. Anyway, if anybody has a Facebook page and they want to put this little blurb that I stuck on mine, just let me know. I mean, it's, you know, like 4 or 5 lines. And I figure if we can put it out, and the more we put it out on, maybe somebody will send something, you know.
Well, if you have children who are grown
Yeah.
and who grew up in this area and are out there working and have friends who are working, they're all using social media, and then you could tweak them to let their friends know that they're, you know, it's sort of a homemade kickstart sort of thing.
Right.
It's amazing what you can do with the social media. So that's, and you know, I have to say, we've done an awful good job raising money, just catch as catch can. And yes, I think we need a plan and we need a director, but you know, what we need to do is do it, even if we do it in little bits and pieces. So we'll get going on that. I would love it if somebody had lots of time and nothing else to do and could go through the town assessors rolls and pick out everybody who has an address that's not in the area.
We've got that, Margaret. It's right in there in the
But that's just for Booth Bay, right?
Booth Bay, but it's the biggest town. So
yeah, and you know, we might send the same letter to those people.
Oh yeah, yeah. And the other thing I did, now my nephew helped. Is it Jason? I don't know his last name.
Jason Sheckley.
down at the movie theater
Yes.
to raise money, and they did it through one of these Kickstart
Yeah.
things. Now, I got in touch with my nephew, and he said, oh, what are you going to give the people for their donation? Because the movie theater gave tickets and other thing, you know, you got so many tickets if you gave so much. And I said, well, we're gonna give them a hospital if we can get enough money, right?
I visited some of those Kickstart things. They'll give you a hug.
Yeah.
You know, we can give them a free flu shot. We can give them a heart.
Well, anyway, he sent me a couple, email addresses, and, I kind of, did you go on and look? Because I went on and looked, and these people were not making a lot of money. The ones that are not giving anything back. So, I'm gonna talk to them some more about it, so hopefully maybe we can do something with that. That's it for me.
Thank you.
Anyone else?
They're all so shy. They're all so shy.
All right, Earl, yes.
Just get up.
I'm not kidding, I guess that's too much in my lap. We're working on an ad to put in the register, 1/8 of a page. And we'll probably try to get together with Sarah down at the register on Friday and get it straightened out, hopefully with the red hearts on it and whatnot. Asking them we need $20,000 for the strategic plan, that fund, okay? And we'll see what happens with that. And as of January 3rd, because they also do it online, we can get an inside page for a week, which I'm not quite sure how that works, but doing the same thing online at that point. If we still think we're gonna need the money, we probably will, let's get real. And we just tell them how many weeks, because it sounded like they lock in, these people lock in. That's why we can't get on before that. They're locked in for a certain period of time.
Right.
And then if you happen to luck out, you just grab whatever spot comes out and go from there. We'll see what happens with that, see how that works.
Thank you.
Okay.
Awesome.
Tell them what it's gonna cost.
What it's gonna cost?
Yes, roughly.
Roughly, it's $180 for
For an eighth.
1/8 of a page, and then in order to get, am I right?
Plus,
It's
Plus-
more like 230
Yes,
for the
because-
eighth of a page,
Plus
because we want the hard
the
in.
heart in red. So it's another $50 for that, so it's like 230, something like that.
But it's
But the
being
on-
donated.
But the online price is like
35.
45.
That was cheap.
So that would, if it worked, it would be far less expensive.
Absolutely.
I'm just curious, are they gonna put that in the Wiscasset paper as well?
Yes.
Yes, it goes into both of them.
Good.
But it didn't seem like it should go beyond that to Brunswick or.
Orange and Lincoln, they said something about Lincoln County, and it's like,
probably not on the county.
It seemed like just Wiscasset and here
it
should
should
cover
be
it.
enough.
Hey.
If we did go on the Lincoln County page, there are a lot of folks up in the Newcastle, Damascotta area that are worried about the impact of us closing down here on them out there.
Enough to donate?
Who knows?
You never know.
So
So does that mean we think about it, is that it?
I'll leave that up to you.
Absolutely.
Uh-huh, okay.
I have faith in you.
I'm glad you do.
Anyone else? All right. Under old business, meeting with Lincoln County Health and Maine Health, we're still trying to coordinate our next meeting with them. Hopefully we'll have something put together soon. That's the update on that.
Well, the only update that I would throw into that is that we're ready, willing, and able, and we're just trying to have them get back to us and respond to us, and we wish they would do it in a timely fashion. Just because we've extended this to October doesn't mean we want to slow this process down, and it's feeling like we're slowing down. We don't want to slow down, we want to keep the pedal to the metal, so.
Well, I know that Jim Donovan spoke with Jim Chaosis today.
Oh, good. I did not know that, I got in here at the last minute.
Unfortunately, with me away from the store this week,
Yeah.
I don't have access to my store email, so that's why the two of them are talking this week. And I'm hoping to hear
Well,
some
we'll
good
keep a
news
good,
from
yes,
you
we'll keep a
tomorrow.
good thought.
Can I ask a question?
Yes.
Are there any licenses that are coming due right around October 1st regarding the hospital?
Not that.
Tell them what you heard, Mary. Oh, right.
Some rumor that October 1st, basically, there's some kind of a deadline in that zone that potentially we could flunk it and therefore there's no hospital anyway. Nobody's heard anything
Not that I'm aware of.
when they're, I mean, because there's times that they come up routinely where they have to pass.
Are they inspected? Is
That's
that
a
evidence? And is inspection?
Regulatory agencies.
There's a survey every 3 years.
It's certainly something we will flesh out to find out what's going on.
Yeah.
I know that the hospital's fiscal year begins October 1st. Or at least it did when it was St. Andrews.
I believe it does.
Yeah. This may
But is
be,
there a certain time for accreditation?
I do not know.
I think there's a requirement by the IRS to community surveys of needs that has to be done every 3 years, starting in tax year 2012. So that may be, I'm only guessing if that's it or not.
Okay.
Good question.
Thank you.
All right. Next meeting, I saw Bruce left. I was hoping that he might have an update on whether or not he had a chance to speak with Scott and Ralph about the public meetings.
I don't know what the deal is on that.
Okay, because I know the last meeting we talked about turning over one of our meetings to them for,
I think they're talking about doing that in January though, but, because we've only got one more meeting left this year, next week.
and it brings us to public comment.
I want to say something.
Sure, Margaret.
If you have not driven by Tom Berry's office in the evening, you need to go by. He's got the most amazing Christmas lights you've ever seen. Big, huge red heart.
Nice.
Mike? No, Tom?
I just wanted to quote a couple of numbers with respect to the magnitude of the issue that we're dealing with. There are 6,000 people on the peninsula. The average cost for healthcare per person remaining is in the order of $7,000. That means that we're spending, one way or another, around $42 million per year on healthcare for the 6,000 people that are year-round residents of the area. The budget for the hospital is roughly half that. It's around $20 million per year of revenues, just as a round number. The overage that we've talked about the ambulance service, the overage that it represents, the increase in its annual operating budget is around $300,000 per year, which has created a huge reaction with respect to what that might mean for taxes in the various towns. Compared to that, what the amount of money that we're trying to raise is altogether pretty small. And we're having our problems raising enough of it. It's in the order of $40,000 to $50,000 that we're going to have to get in order to fund this effort, which ultimately is aimed at the quality of care that can be delivered, for which the total cost is around $40 million per year. I just want to make sure that everybody has all of these numbers sort of in mind as what this effort is all about. We're talking about raising $40,000, $50,000 for an effort that's in the order of 1,000 times its size, which is the cost of health care for everybody on the peninsula. I just want to make sure that everybody has that in mind.
Good perspective, thank you.
Did you have something, Mike?
Yeah, I've got a couple of observations. I'll start with the most boring ones first. I've been trying to understand fiduciary responsibility. It's better than Sonics. But a very interesting thing came up, and I actually consulted with a lawyer friend of mine.
And when you talk about fiduciary responsibility and the neglect thereof, you don't have to prove intent. In other words, if you accuse somebody of committing larceny, you have to accuse them of intending to do that. But there doesn't have to be intent. It can just happen over time. And it doesn't necessarily become anyone's specific fault. It just happens. If you read the position paper, and that gives quite a history, that kind of describes what happened without intent. Without intent. So my point is that we can direct our anger, it's their fault, it's their fault. Well, it's the fault of a lot of folks over a lot of time. So we're not talking about individuals anymore, or we're not talking about individual corporate entities, but we're not angry at individual people right now. It's not that. It's what happened over time. I think that's an interesting thing to bear in mind when we're talking and negotiating with Lincoln County and so forth. Secondly, what I'm struck with is Patty's report. There's 30 ideas in here of how to do it differently. 30 ideas that were not addressed in the Navigate report. I wonder if they were addressed by Maine Health or Lincoln County. We don't know. We have no way of knowing until we ask and find out if they'll tell us. But here's a whole bunch of ideas. I'm assuming this is shared with iAdvantage.
Yeah.
And we're actually being more creative than the original report that closed the hospital contained. Absolutely more.
There's no question.
By going out there and asking, did Navigate travel to Machias? Did they go to Bolton and stay at Ivy's?
They probably missed that opportunity.
Anybody else here ever stayed at Ivy's? It's great. No offense, Ivy, but apparently there's another choice.
It was fine.
It's an adventure in Maine. Last, I want to address one thing Peggy said about worry. It's something that gives me great solace, and that's, you can't always do this, I'm not all that good at it, but you have to remember, worry is wasted imagination.
Ooh, that's nice.
If you use your imagination, instead of worrying about all these things that go wrong, use it to find the solution. If you can make yourself redirect that way, wow, you can do just about anything you set out to do. Nobody's perfect at it. But just recall, worry is wasted imagination. I'm worried about the hospital closing, and I'm trying to use my imagination to find a way to prevent that.
Amen.
That's great.
Somebody took joke of that.
Okay.
I have one other thing that I wanted to bring to your attention, thanks Mike, that I glossed over in this summary, which had to do with the affiliate relationship. We talked to every single hospital about whether or not they had an affiliate relationship and what benefits they got out of it, and if they didn't have it, why they should. And basically they all said, you need an affiliate. Because, as I mentioned before, the billing and so on is very complicated, but there are different levels of affiliate relationships. You don't necessarily have to be a wholly owned subsidiary of an organization that you're affiliated with. You can buy services from them. And so there's a list of things that, that people say are good. Having best practices support, having somebody fill your swing beds, providing specialists. But the most interesting thing was when they started talking about what the governance structure should be. And basically what several people said was, when you really want your own board, it should be local, it should be made up of community members. It should not have on it the management team of the hospital. They, one or two of them turn up as ex officio members, but they're not on the board.
They should report to, but not be part of.
Right, and if you're going to have doctors on the board, limit it to 1 or 2. If you have 5 or 6 or 7 doctors on a board, you're toast, because they will basically run everything and they'll convince everybody that what they want is right. And so it's not that you don't want any physicians, but they shouldn't be running your board. So I thought that was probably useful for you guys as you're thinking about trying to work things out.
Amen.
Motion to adjourn?
I move that we adjourn. You second
I
it?
second.
Well, that works out.
Thank you all for coming out tonight.
I'm gonna bring my presents and we're all gonna wrap.
All right.